happy to be able to introduce Dr. Kurtz this morning for Grand Rounds. He joined our group in pediatric cardiology just this summer, and his background, his medical school was in Buffalo, and then pediatric residency was at Miami Children's, and then he went from there to Charleston, South Carolina for pediatric cardiology fellowship at Medical University of South Carolina, and then did an additional year in interventional cardiology at Seattle Children's before coming and joining us as faculty this past summer. So we're very happy to have him. His path took him all around the country, from upstate New York to South Florida to the Pacific Northwest, before landing him here with us in Louisville. And maybe a side note for everyone today, I think he can give you a recommendation on buffalo wings in Louisville that are closest to the original recipe from his med school days in Buffalo. So put that in your hat and find him later. So professionally in his cardiology work, obviously interventional cardiology is his specialty training, but he has an interest in Fontan patients who start off with single ventricle heart disease, and that has led to him getting a grant when he was in his pediatric cardiology fellowship in South Carolina to look at the underlying physiology that leads to liver failure in a lot of our Fontan patients as they get older. And I'm actually very happy to say that he's been able to transfer that grant here recently to continue that project. He's also did a project while he was at Seattle Children's looking specifically at feeding in Fontans or single ventricle patients when they're newborns and how that impacts their outcomes. And we here have been looking at that closely also. Recently, we're part of a national collaborative on single ventricle care, and feeding is a big part of how they do before their surgery, after their surgery, discharge to home, before their next surgery. And so we have been talking here actively about trying to optimize what we do, and it was a really nice fit that Dr. Kurtz has actually had some experience looking at what they were doing in Seattle as part of his fellow project. And so we're going to have him talk today about single ventricle heart defects, feeding growth outcomes. So thanks very much, and thanks to Josh.
Can everyone hear me?
Yes, we can.
Perfect, thank you. So thank you, Dr. Holland. So I'm Josh Kurtz. I'm a new faculty member here in the Division of Pediatric Cardiology and one of our interventional pediatric cardiologists. I'm going to talk today about single ventricle heart defects and how feeding and growth impact their outcomes. I have no relevant financial disclosures. My goals today are to describe the epidemiology of supplemental feeding dependence in single ventricle infants, discuss the factors that put this population at risk for feeding dysfunction, compare the current interventions being used to improve oral feeding tolerance, and examine future directions to improve feeding dysfunction in the single ventricle infants. So first we need to talk about the scope of the problem. Congenital heart disease is the most common congenital defect. It affects about 8 in 1,000 live births, and single ventricle heart lesions are a heterogeneous group that combine to make up about 2 to 4% of the congenital heart disease population. While this is not a large number of live births, they have numerous comorbidities that lead to interaction with almost all specialties and require a large amount of healthcare resource utilization. Infants with single ventricle anatomy are at risk for multiple comorbidities, chief amongst them failure to thrive, feeding dysfunction, and prolonged supplemental tube feeding. Estimates vary by how you look at it, but anywhere from 25 to 75% of infants with single ventricle anatomy are discharged with a feeding tube. When comparing this to another high-risk population for feeding dysfunction and supplemental feeding requirements, premature infants, published studies again vary by criteria, but in a large multi-center cohort, 7.3% of extremely low birth weight infants, those weighing less than a kilogram, require G-tube at some point. When liberalizing that criteria, anywhere from 26 to 40% of babies born less than 37 weeks require supplemental tube feedings at the time of discharge. By 1 year of age, only 22% more of these were able to transition to exclusive oral feeding. I highlight this number because we're going to look at the similar statistic in the single ventricle population in a little bit. It's important to look at feeding dysfunction and supplemental feeding in these populations because you can see here in the premature population, there are significant clinical differences between the two groups. Those who required G-tube feeding had later age at first oral feeds, longer ventilator courses, and significantly more respiratory support. That's what the graphs on the left are showing. This suggests that those requiring G-tube feeds are a sicker population, and this may be one of the reasons why they start to feed later. When you look at the graphs on the right, these all look at realms of development, the top one being cognitive, the middle communicative, and the bottom motor delay. In all of these, the percent of patients discharged with G-tube feeds are higher for those who have delay. Or sorry, those who are discharged with G-tube have a higher percent of being delayed in each of these realms compared to those who are orally fed. Nutrition is a very important part of neonatal health. And in addition to feeding dysfunction, there are multiple reasons why children with congenital heart disease have poor nutrition. Frequently in their heart failure, they have increased nutritional requirements. There's a high rate of gastroesophageal reflux disease in this population. Those who have heterotaxy are at risk for malrotation, and their fetal environment changes that actually already put them at risk for poor nutrition prior to birth. Poor nutrition has been associated with worse mortality, morbidity, and neurodevelopmental outcomes in the single ventricle population. One of the ways to prevent that was to use supplemental tube feeding, as this was a way to encourage enteral nutrition, improve nutrition, and therefore improve the mortality and morbidity associated with the poor nutrition. Unfortunately, just like with the premature infants, it's been shown that those requiring supplemental tube feeding in single ventricles have been associated with developmental and psychomotor delay, worse somatic growth, increased interstage mortality, longer hospitalization at stage 2 palliation, and is a significant cause of anxiety amongst caregivers. So despite the fact that this was used as a way to benefit these patients, this really didn't change any of the outcomes. The interstage period, that time between stage 1 palliation discharge and admission for their Glenn surgery, is a tenuous high-risk period with significant mortality. One of the ways we kind of judged ourselves in congenital heart disease and our success has been what our mortality rate is. And so the National Pediatric Cardiology Quality Improvement Collaborative, this was actually the collaborative that Dr. Holland was speaking about a few minutes ago, sought to look for what are some of the risk factors for mortality in that interstage period in a way that we can then target these to improve mortality. What they found was there were 3 independent risk factors for mortality in the interstage period: gestational age, feeding route, and postoperative vasoactive medications. The graph on the left looks at gestational age, the gray bars being percentage of cases and black being mortality rate. As you can see, prior to 34 weeks gestational birth is a significant risk factor for mortality. When looking at the graph on the right, again, the different number of vasoactive medications have very significant differences in risk of mortality. The middle chart is looking at feeding route, and here those who are NG or NJ fed had significantly greater risk compared to those who are oral or G-tube fed. This led them to conclude that this is one of the only modifiable risk factors for decreasing interstage mortality. While there are things that we can do to delay birth, once the baby's born, unfortunately gestational age is a set factor, and the number of postoperative vasomedications a patient is on is for a reason. Either they're not able to tolerate more or they're requiring more depending on their situation. So they decided that this is one of the only variable they found that they could really target. While mortality has been one of the main ways we've judged our success in congenital heart disease, over the last few decades, mortality has improved greatly, and we no longer are just wanting these kids to live, but actually thrive and live fulfilling lives similar to other children. So as mortality outcomes have improved, functional and developmental outcomes are becoming much more important. This is a study done at the Children's Hospital of Philadelphia looking at the difference in development, comparing those who were tube-assisted feeding compared to those who were orally fed, in all babies who underwent complex congenital heart disease in the first 30 days of life. So you can see being tube-assisted feeding at discharge was associated with lower mental and psychomotor developmental index scores at 6 months of age. If they still required tube feeding at 3 months of age, the mental and psychomotor developmental index scores were still lower at 6 months of age, but psychomotor developmental index scores continued to be lower at 12 months of age. They also separated the population out here by those who underwent biventricular repair compared to those who underwent single ventricle repair. And in all categories, single ventricle infants already had lower developmental index scores compared to the biventricular repair when all other things being equal. So this is already a high-risk population we're talking about, and there are a number of reasons for this that we'll discuss shortly. When looking at the large multivariable model, device-assisted feeding at 3 months of age was still independently associated with lower psychomental, developmental index scores at 6 months of age. Here's another study looking at development in those undergoing complex congenital heart surgery in the first 6 weeks of life. And while this is a busy chart, I want to highlight the column on the right, showing that every variable they looked at reached statistical significance. So the first few measures are of somatic growth, height, weight, and head circumference were all lower in the G-tube fed group. The next few were related to healthcare resource utilization, number of hospitalizations for both cardiac and non-cardiac treatment, number of specialists seen, as well as the number of chronic medications they were on. And then the last half is all related to developmental outcomes. And again, each realm of development was statistically worse in those who required G-tube feeding compared to those who didn't. When looking at the odds ratios, those who were G-tube fed were 8 times as likely to have a cognitive delay, 3 times as likely to have a language delay, and 9 times as likely to have motor delay. These are the way we see these babies clinically in the early prenatal and infant period, but there have actually been studies going on looking at changes in the in utero environment, and it's been shown that there are actually MRI changes in the brains of babies with complex congenital heart disease starting in the 3rd trimester. Babies with HLHS have been shown to have decreased gray and white matter, lower gyrification indexes, and smaller cortical surface areas compared to normal controls. They've also been found to have cerebral lactate production, suggesting local hypoxia, and this may be one of the reasons for these early changes. Another study looking at babies with hypoplastic left heart syndrome and transposition of the great arteries have shown smaller head circumference and lower total maturation scores. These lower total maturation scores are more equivalent to somebody who was born 4 weeks gestationally earlier than these babies. And that's what the graph on the right looks at here. The box plot on the left in dark gray shows the total maturation score for a term baby born between 38 and 43 weeks. The middle plot in light gray, those who are late preterm, 36 to 37 weeks. And the box plot on the right is those with complex congenital heart disease born between 37 and 41 weeks. Again, even the late preterm infants have significant lower total maturation scores compared to term infants, but even term babies with complex congenital heart disease have lower total maturation scores than the late preterm infants. These MRI changes don't just happen in utero, but they continue to show progress after birth. And so the graph here is looking at the change in MRI of fractional anisotropy of the white matter. This is a measure of microstructural development of the brain in an MRI of single ventricle infants shortly after birth, and then a second one shortly after their stage 1 palliation. So these are all single ventricle infants who underwent stage 1 palliation, and then measured their, compared this amongst feeding route at the time of their Glenn. So then looking down the road how they were feeding. The red bar shows the change in fractional anisotropy for those who required 2 assisted feeding at their Glenn, and the black was those who had oral feeding at their Glenn. So as you can see, even in that early postoperative period, there's already changes in the brain going on for those that are able to feed orally compared to those who are not. What this showed was their slower rate of postnatal brain maturation associated with feeding modality in infancy. However, there was not an association with preoperative brain injury and feeding modality at the Glenn. So our typical concerned brain injuries, things like infarcts or bleeds, did not actually have an association with feeding route, but there were smaller, more functional changes that did. And this emphasizes the importance of overall brain health and optimizing our feeding outcomes. It's still not known exactly how intrauterine neurodevelopment abnormalities impact postnatal neurodevelopment and developmental delays. It includes feeding dysfunction risk. We still don't know what risk this poses for worsening deficits after cardiopulmonary bypass, and there's a concern for a worsening cycle here. So as we mentioned, there's already intrauterine delays that are going to lead to poor nutrition and poor feeding. We said that poor nutrition and poor feeding leads to more delays. They're then going to undergo cardiopulmonary bypass, which is going to lead to delay in nutrition and already associated with developmental delays. And you can see how this is just going to start cycling on itself to make things worse and worse and worse. The Cardiac Neurodevelopmental Outcome Collaborative, or CNOC, has done a lot of great work on this topic, and I highly recommend anyone interested in this to take a look at some of their work or attend their symposium that they're now hosting yearly. So my interest as a fellow at MUSC was in single ventricle physiology and the hemodynamics and why this is such a high-risk population and how we can improve the outcomes in this population. As I kind of mentioned with all the data up till now, it became clear that oral feeding route, or the ability to have these kids feed orally, is one of the best ways that we can improve the long-term outcomes and the short-term outcomes in these kids. And so I underwent a study trying to find the factors associated with delayed transition to oral feeding in infants with single ventricle physiology. The goals of the study were to describe the incidence of G-tube dependence at time of stage 1 hospital discharge, to describe the duration of time to achieve exclusive oral feeding in infants with single ventricle physiology, and to identify risk factors associated with prolonged gastrostomy tube dependence. This is the look at our cohort. There were 78 infants, all with single ventricle anatomy and who underwent a stage 1 palliation. So those who underwent primary Glenn procedure were excluded. Overall, 39 or 50% of the infants were able to achieve what we considered early oral feeding. So those who were exclusively oral fed by the time of their stage 2 or Glenn palliation. Another 14 infants, or 18%, achieved what we considered the middle transition. And so this was those who could not achieve exclusive oral feeding by stage 2, but did prior to 1 year of age. And then 18 babies, or 23%, did not transition by 1 year of age. Lastly, 7 babies, or 9%, unfortunately passed away prior to 1 year of age. To highlight some of this in comparison to other numbers, again, that 18% is similar to what we found in the 22% of babies who were able to achieve later exclusive oral feeding by 1 year of age. But still, only about 2/3 of the babies overall could achieve oral feeding by 1 year of age, and nearly a quarter did not achieve that exclusive oral feeding. Of note, just based on the protocols at MUSC at the time, all babies discharged with some supplemental tube feeding were G-tube fed, so none of these babies were discharged with an NG tube. When looking at our cohort, it was a heterogeneous group. There was a big mix of ventricular morphology. There were a number of different stage 1 surgeries. But to highlight these in the middle here, 46 patients, or basically 3 in 5, did require G-tube placement at some point. And only 36 babies, or 46%, so less than half, had any preoperative oral feeding. This includes even just trophics at 1 feed. This is all the variables that we found were associated in different ways with the different transition groups. And so while there's a very busy slide, I'll kind of summarize the results here. The variables associated with being able to transition early, so being able to orally feed completely by the stage 2 palliation compared to the later groups, was these babies had more likely to have preoperative oral feeding. They had fewer cardiac medications at their stage 1 palliation discharge. They were less likely to have a prolonged enteral sedation taper. They had shorter hospital length of stay, and they had a less degree of AV valve regurgitation at stage 1 hospital discharge. When comparing just the early group to those who were to the middle group, those who achieved oral feeding after Glenn but prior to 1 year of age, the early group had higher O2 saturations at stage 1 palliation discharge and a higher weight for age Z-score at Glenn admission. And now comparing the early group to just those who never achieved exclusive oral feeding by 1 year of age, the early group had higher weight for age Z-scores at stage 1 palliation discharge, shorter length of intubation, and shorter length of initial ICU course. Just as interesting as what was associated with the ability to transition early was what was not associated. And so having preoperative non-oral enteral feeding did not actually help. So just priming the gut for enteral nutrition did not actually improve the ability to transition to oral feeding later on. The type of initial surgery and underlying anatomy, so meaning that hypoplastic left heart syndrome or those who underwent a full Norwood did not actually have more difficulty transitioning to oral feeding. Those with vocal cord paralysis did not have more difficulty. If patients received rehabilitation therapy, so PT, OT, or speech therapy, did not actually help, and this was either after the stage 1 or stage 2 palliation. And then chromosomal abnormalities and neurologic injury did not have any association with an inability to transition earlier to oral feeding. There was a lot of data we looked at, and so then we went into a multivariable model. And what we found is there were a few independent risk factors for the inability to achieve exclusive oral feeding. And so when looking just at that early groups and the inability to achieve exclusive oral feeding by Glenn palliation, we found that no preoperative oral feeding was one of the independent risk factors. And so those babies who did not feed preoperatively were 12% as likely to achieve exclusive oral feeding by the Glenn palliation. And greater number of cardiac medications. So for each extra cardiac medication a patient was on at discharge, they were 3.82 times as likely not to be able to achieve exclusive oral feeding by Glenn. When looking at the inability to achieve that middle group, so not being able to achieve oral feeding by 1 year of age, again, no preoperative oral feeding was found. This time 9% is likely, and longer initial ICU duration. So for each additional day in the ICU, there was 1.05 chance, more chance that you would not be able to achieve exclusive oral feeding by 1 year of age. The thing to notice here is there's only one variable that seems to stick through all the analysis, whether it be univariable or multivariable, and in the different groups, and that's no preoperative oral feeding. This is notable because this is something we can adjust. And so while, again, there's usually a reason why patients are on a greater number of cardiac medications, or for the most part, patients are in the ICU for a reason and not able to be moved to the floor or sent home, preoperative oral feeding is something that we can look at. And so oral feeding is preoperatively is a modifiable risk factor that we may be able to use to decrease the length of supplemental feeding requirement and all the associated comorbidities that go along with it. So if this is shown to be such an important factor and something that we can do to improve our outcomes, why is there such a hesitancy to feed preoperatively? Well, unfortunately, there are a number of very good reasons. These are patients on vasoactive medications. They're on prostaglandin. That's usually for either systemic or pulmonary dependent ductal blood flow, decreased cardiac output and unbalanced circulation, and all of these put babies at risk for necrotizing enterocolitis. While these are all good concerns, there are a number of studies over the last few years looking at feeding on vasoactive medications, but especially feeding on prostaglandin, and has shown that this can be done safely with minimal increased risk of adverse events, especially related to the mesenteric system and neck. The other concern is, even if these patients look stable at baseline, they have an increased metabolic demand, and the extra energy required to physically feed or digest the food may be enough to tip them over the edge and put them into an uncompensated state, putting them at risk for all the other outcomes that we were concerned about. So while neck is one of these biggest concerns and really the underlying disease that comes from all of those concerns, there was a study at MUSC shortly before mine that looked at all neonatal heart surgeries for a 2-year period and found there was no difference in neck rate in those who were fed preoperatively compared to those who were not. The one thing they did find was, again, this was a shorter ventilator course for those who did have some preoperative oral feeding. One of the biggest concerns for neck is due to mesenteric ischemia related to the Steele phenomenon, and this has to do with the ductus being open and blood flow going preferentially to the pulmonary system as opposed to systemic system. Though neck has been looked at significantly in this population and in general in the premature population as well, and there have been a number of studies showing that if breast milk is used, this is a protective factor, and that almost all babies can be safely fed using breast milk to lower their risk of neck. Obviously, this is parent and family dependent, but they've also looked at this using donor breast milk. When this is available, this can be nearly equivalent to family breast milk as well. So one of the reasons it's so important to feed in this early period is studies in the neonatal intensive care unit have shown there are what they call developmental critical periods. These are times where an infant is ready to achieve a developmental milestone, and if they're not given the opportunity to achieve that developmental milestone in that time, they might have a more difficult time later on. And so we know for feeding, this is very early in the neonatal period, and so they don't have a chance to attempt feeding in that time period. When this time is missed, they may develop oral aversion or even refuse oral feeding attempts later. And so we need to find a way that we can standardize feeding to minimize risk and maximize benefit. This will ensure early introduction of oral feeding and improve all of the outcomes that are associated with this early oral feeding and delaying supplemental tube feeding. One of the best ways that's been shown to do this is with standardized feeding protocols. And there have been a number of studies looking at these over the last few years. This first one in the neonatal intensive care units looked at those number of patients who were discharged home with either an NG or G tube prior to the introduction of a standardized feeding protocol, and those who and the rates afterwards. So the gray speckled and gray solid bars on the left represent those sent home on NG or G tube feeding respectively prior to the introduction of the feeding protocol, and the black and white bars on the right are NG and G tube respectively after the introduction of the feeding protocol. And as you can see, at almost every gestational age, the rate of feeding tube dependence was lower after the introduction of the standardized feeding protocol. The bars on the right represent the summation of the cohort and show a statistically significant difference between those who required supplemental feeding at the time of discharge before the introduction compared to afterwards. they were able to reduce this from 26% to 15% overall. Additionally, they found that babies in the standardized feeding protocol group were discharged at a younger postmenstrual age and trended toward shorter length of stay, though this did not reach statistical significance. So this was taken from a lot of the premature infants and then put onto babies with cardiac disease. And so these are two studies that actually just recently came out. Neither are in print yet. They're still just in press this month, looking at standardized feeding protocols in either the cardiac intensive care unit or the neonatal intensive care unit with cardiac babies. And so both graphs look at the y-axis of weight for age z-score change over hospital length of stay. So this is how much weight relatively is lost. And so a less negative number is better. And so the graph on the left is looking at the Children's Hospital of Philadelphia. And 2013 was the year they introduced their standardized feeding protocol. And you can see that is the year there was a significant jump in the weight for age z-score change over hospital length of stay, so that their weight loss, relatively speaking, was significantly worse. When they separated out babies who underwent biventricular repair and those who had single ventricle anatomy, again, this same graph pretty much held true for that population. There was no increase in mortality, neck, or hospital length of stay, again, in the total cohort or in the single ventricle population. The second graph is from the Vanderbilt Children's Hospital, and again, is looking at the same thing. It's the weight for age z-score change over hospitalization before and after feeding protocols. And so the magenta bar on the left is what they called phase 0. So this was their historical control prior to any feeding protocol. The silver bar in the middle was after a post-operative feeding protocol. And the gold bar on the right was after a preoperative feeding protocol. And again, the weight for age z-score significantly improved when you compare phase 0 to phase 1 and phase 2. Also of note that they were able to increase their preoperative feeding rate to 76% after phase 2. This is a significant increase compared to the less than 50% we had at MUSC in our kind of standard group. Again, there was no increase in neck in any of these phases. So again, the biggest thing here looking at standardized feeding protocol is it can be used to safely feed without increasing neck risk. And so the NPC QIC that we've talked a lot about today has put out feeding protocols, and both Vanderbilt and CHOP are members of this, and their protocols are pretty much based on this one. But what I want to highlight in the NPC QIC protocol is really how simple it is. They essentially have one requirement to feed. And so they start with the kind of normal preoperative feeding and nutrition assessment, feeding evaluation, hemodynamic assessment, and dietitian evaluation, followed by starting parenteral nutrition. And then right away, they look to see if it's safe to feed. Like I said, they have one requirement, and that's it: assure adequate cardiac output. As long as clinically the baby has adequate cardiac output, which they define as using things such as blood pressure, urine output, and skin tone, the baby's safe to feed. They highlight again that it's safe to feed with an umbilical arterial line or on prostaglandin, but do note the controversy in using NG feeds, as babies who do have mesenteric ischemia are thought to self-limit, and if they are having discomfort due to mesenteric ischemia, will not feed, versus force-feeding babies that may put them over the edge to risk for GI complications. They do note to initiate low-volume oral feeds and advance slowly as tolerated, and again, highlight the preference of human milk followed by donor milk, and only using formula as a third option. Lastly, they recommend continuing to reassess daily for evidence of impaired perfusion, early shock, and GI complications. In addition to this preoperative feeding protocol, they have a postoperative as well. And I think it's very important in our institution to look at this, because we have these babies in two different units, preoperatively and postoperatively. And if they're being fed preoperatively in the NICU based on the protocol, but then do not have early reintroduction of feeds postoperatively, everything that was gained preoperatively could be lost. And vice versa, if we start feeding kids postoperatively early, but they weren't primed to feed preoperatively, we may not see that benefit. Another intervention that's been looked at is oral motor interventions. There's been mixed evidence if premature infant oral motor intervention improves time to exclusive oral feeding and developmental outcomes in premature neonates. Small studies of premature infant oral motor intervention have shown promise, but large systematic reviews have not shown strong benefit. There's actually been a prospective study using oral motor intervention compared to historical controls in those with single ventricle anatomy. Unfortunately, it did not show any increase in exclusive oral feeding in infants at stage 1 discharge. I mentioned earlier the study that I did not show any difference in feeding to those who received PT, OT, and speech therapy. And while these did not have any standardized intervention, the idea that they underwent rehab therapies would suggest that if there was an oral motor intervention that would be helpful, they should have shown some benefit. One of the more recent interventions that's been used in the single ventricle population is digital home monitoring. For those of you who are not familiar with this, over the last decade, pretty much all centers, including ours, who see interstage infants have some form of digital home monitoring. It's something that's integrated into the EMR, and parents are asked to input saturations and weights daily, as well as red flag symptoms. These are things such as increased diaphoresis, increased work of breathing, more fatigue, or vomiting. More recently, these have included something like an iPad or iPhone, and it has included taking videos daily so that the providers and physicians can actually see the work of breathing or the skin tone to help see which babies are at higher risk and need more closer follow-up. What the University of Virginia and Rainbow Babies did is they actually started integrating feeding into this and started including daily video visits over the iPad to address feeding advancement. What this allowed them to do was increase their exclusive oral feeding rate by 1 year of age to 90%. That was significantly greater than their 70% prior to introduction. And if you look at that, 70% as a historical control is very similar to the amount that we had at MUSC with 68%, and fairly similar to the discharge of the premature babies in the studies looking at their feeding requirements. And why this was so helpful was usually as close as these babies are followed, they usually only have follow-up every 1 to 2 weeks. And so if feeding is weighted to be advanced every 1 to 2 weeks, this is going to significantly slow the feeding in that period, especially after the stage 2 palliation, as they no longer are in this interstage monitoring and may not have that feeding advancement addressed at that time. In addition to the significant increase in rate of oral feeding, they found in this group that they were able to decrease the hospital length of stay for their stage 1 palliations. They theorized that the reason they did this is providers were more comfortable sending these patients home on low volume oral feeds, knowing that it was going to be addressed early in the outpatient setting. Frequently, these patients are kept in a hospital for a number of weeks while we try to advance to higher feedings, or maybe even see if they can achieve full oral feeding before sending them home with a supplemental feeding tube. Next, feeding tube dependence may be a risk factor in and of itself. This may represent a red flag of worse disease and heart function, and it can be used to risk stratify patients in the interstage period. The feeding tube dependent patients may be the ones who need medication adjustments, more frequent follow-up, or could actually even be an indication for early stage 2 palliation to get them out of this high-risk interstage period. A number of studies have suggested this, including secondary analysis of the single ventricle reconstruction trial, and though it's never been independently evaluated, it does seem to make sense as one of the high-risk factors. And so where do we go from here? We need larger multi-center study to verify these results. The MPC-QIC has 2 projects in the design phase currently looking at this. One will be looking specifically at a standardized preoperative feeding protocol, and another specifically looking at how to wean these patients from supplemental feeding tubes. As I said, we need a prospective study to determine if standardized feeding protocols improve preoperative feeding adherence and decrease feeding tube time requirement. This is what the MPC-QIC is seeking. And we need further investigations into the role of fetal brain development on the impact of oral feeding in infants with single ventricle anatomy. In conclusion, feeding dysfunction is a common problem in single ventricle heart disease and requires multiple specialties for the best outcomes. Exclusive oral feeding route decreases resource utilization, is associated with better neurodevelopmental outcomes, and associated with decreased mortality. I want to highlight these next 2 because I think these are the 2 things that we can target and actually intervene on to improve our outcomes. That's preoperative oral feeding may be a modifiable risk factor that can decrease time of postoperative feeding tube dependence. And standardized feeding protocols can be used to safely increase the rate of oral feeding while minimizing risks. Feeding tube dependence may represent children with more severe disease and can be used as a method of risk stratification. We need further investigations into the role of fetal brain development on the impact of oral feeding in infants with single ventricle anatomy. And we need to continue to monitor neurodevelopment, as we need to determine if neurodevelopmental intervention improves oral feeding. We need to decrease the risk of oral aversion and because an inability to feed orally may be a marker or risk factor for neurodevelopmental delay later on. Thank you for your time, and I'll take any questions.
So Josh, it's Brian. Can you hear me?
Yep.
That was really well done. A couple things from my standpoint. You mentioned the fact that the NPC-QIC feeding protocol was pretty streamlined, and that the only thing that they looked at to decide whether it was safe to try oral feedings preoperatively was whether there was adequate cardiac output. Could you say a little bit more about exactly what goes into the definition of what adequate cardiac output is in the preoperative single ventricle patient?
Yeah, and so the NPC-QIC does have kind of their specific guidelines. It does have their definition, but really in brief, they don't really give a lot of details. Essentially, if you have basic clinical signs, making urine, clinically good peripheral perfusion, that's pretty much adequate for them saying that this is probably a baby who's safe to feed. There really aren't a lot of the metrics trying to look at it. I think mostly because their goal is to get as many of these babies to feed as possible.
Okay. And I am watching some of the scroll go by with some of the questions that are typed up, which actually was one of the same things I was going to ask. And it's come up in some discussions here that we've been having for these patients. And that has to do with the timing of the first surgery. So if we are going to surgery not usually 24 hours, but sometimes 48 hours, 72 hours after the babies are born, a lot of times we've thought that maybe that's inadequate time to get them stabilized, make an assessment, and try a feed, and that it may, quote unquote, not be worth it. Was there anything that you did in South Carolina or that you've seen that shows the average time of the first surgery, or whether there was any difference in how much time there was in relation to whether that trial of oral feeding was effective?
Yeah, so I said this was a bit of a mixed group, so it wasn't only Norwoods, and some of the non-Norwoods were given a chance to see if they were balanced, and so they may have gone to surgery a little later. The average age of surgery was still less than a week old, though. While it was hard to decipher out here, as I did say, the hypoplasts and those who did undergo Norwood, which were usually earlier, though maybe a day or so later than we do here, had no difference. So it wasn't that time decreased the chance of having oral feeds. But when actually, if you look at the individual data we had, and it was hard to put all this up there, most of the babies really did have really short courses of just trophic feeds. It really could have only been, probably 12 to 24 hours a lot of the time, but that did seem to be enough, having just that early trophic feeding to at least get some those oral motor skills down that probably were associated with improved outcomes later.
Okay. The other thing I wanted to ask, I know that when you did all your analyses, that the feeding orally was the one that was consistently found to be associated with the outcomes that you were looking for. It looked like in some of the analysis, sedation was also associated, and it looked to me like that is another potential modifiable risk factor, and something that has also potential to benefit from a protocol. If you said post stage 1 in the hospital, patients who were on more sedation and on more sedation longer and had a longer, slower taper seem to have worse outcomes, that could be another potential target. As I was looking at that, is there anyone that is looking at sedation protocols specifically in this type of population?
I'm not sure if anyone has looked specifically at sedation and feeding. Unfortunately, at this point, there are a number of different groups looking at it, but there are more hemodynamic factors that have been looked at. In our analysis, there were a univariable analysis. Sedation was associated with the ability to transition early, though what we actually considered a prolonged sedation taper was those who required prolonged oral medication at home. So it wasn't that in the kind of ICU you required morphine or fentanyl for a long period of time. It was actually required either oxy or that what we sent our kids home on at MUSC, but some benefit for prolonged sedation at home.
Okay. I got one more question, and then I'm going to stop monopolizing the post-lecture discussion. At the end, you mentioned the home video monitoring that they were doing. It sounds like UVA and Rainbow Babies were the two centers that were showing increased feedings that was actually actively improving with more active management. And now that we have those iPads and we've got the ability to do some more things, there's a nice potential there too. Was that daily assessment with a speech therapist? Do you know what the assessment was on the daily video feeding assessment that was able to have them increase the amount of feeding by a year in those patients?
I believe it was by the dietitian, actually, though I think it was a mix. So that paper I actually don't think has been published yet. I saw Jeff Regalis present it at AAP last year, so it's another pretty new one. But I do believe he said that they mixed, that it was mostly the dietitian, but that there were mixed with, the single ventricle nurse practitioner or single ventricle physician, because when they would do their weekly visits, that's who would take those days, and then most of the intervening days were with the dietitian. As it was not as much a oral motor intervention as it was truly going over, okay, how much was tolerated orally versus how much required supplemental feeding, and then doing the feeding advancement based on that.
Okay, great, thanks. I'm going to let other people ask you some questions.
And just really quickly, I see one in the comments, gender differences. No, there were no associated gender differences.
Hey Josh, this is Tamina from the NICU. Great talk. Thank you so much. You're preaching to the NICU choir here. I am looking at our current guidelines, and so yes, we placed a great deal of emphasis on nutrition in general. And so in our guidelines, we start TPN on day of life 1. We did try to get a little more granular with the adequate cardiac output piece, just to encourage folks that we would feel safe feeding these babies. So we have some guidelines regarding lactates, dopamine and epi doses, that kind of thing, just to be a little more clear about cardiac output. But I like the pieces about the blood pressure and the urine output. We could probably include those as well. Maternal breast milk is definitely our first line. And for our NICU population, the less than 1,500 gram babies who are at the highest neck risk are those that are able to receive donor breast milk, but the single ventricle population as well. So just to stress that. And the guideline, of course, is initial feeds, like you talked about, trophic at 20 per kilo, and advancing by 20 per kilo as long as the baby is taking oral feed, so as not to, sort of force feed them with a tube feed. So we really are anxious to really get these babies orally feeding early. I would love to get them to the breast, which is the best way to do this. Sometimes there are challenges with lines and tubes and all the rest of it. But our NICU nursing staff are really great about getting babies up safely. And so really glad that you started this conversation again. Thank you.
Yeah, and I think you can see I even stole a lot of NICU literature for this, because you guys have obviously been the ones leading the way, and the standardized feeding protocols were started way earlier in the NICU than they were in the cardiac world.
Yeah.
And so I think that's, an important thing. The only thing that I think in kind of my research, and obviously this is going to be a bias of cardiologists versus neonatologists, is that we've kind of highlighted a lot the safety to feed even if there is DOPA or epi, as long as they're still maintaining some cardiac output, that the constriction may not be as concerning as just the true mesenteric ischemia.
Exactly.
All right, thank you everyone for joining us. If you have any more questions, I've included Dr. Kurtz's email in the chat, and feel free to reach out to him with further questions, and we will conclude Grand Rounds with that.